Next is, what is the pathology? I told you, there may be a history of trauma, may be significant or may not be significant. What is happening when there is a trauma? There is extravasation of blood. More specifically, when it happens in the metaphysis or in and around metaphysis, whenever there is a collection of blood which is not getting absorbed over a period of time, that acts as a nidus or a food for these bacteria to stay there, eat that food and then get multiplied. So, there may be a history of trauma, and usually the pathology starts in metaphysis where there is a vascular stasis because of the turbulence of conversion of a high velocity arteriolar blood into a low velocity venous blood. Suddenly there is a turbulence as well as a stop or stagnation for some period of time because of the hairpin bends. You have a vascular stasis and you have the bacteria coming there, lodging there, multiplying and mounting an inflammatory response. That acute inflammation will be there, lot of bacteria will be there, lot of pus formation will be there, lot of immunological reactions going on over there, edema and all those things, raising the intra-osseous pressure. Once there is a raise in the intra-osseous pressure, what happens? Whatever the bone that is getting blood supply to these Haversian systems is now blocked. Hence, blood supply to the bone is blocked, the bone is going into a phase of anoxia, and usually that part of the bone where this tension is increased, now the bone becomes necrotic. Once the bone becomes necrotic, what will happen? It is died off. It is called as sequestration of the bone. Now, because of the immunological pathology and all these things, you have a lot of pus being formed inside. Now, pus cannot stay there because every day it is forming, more and more bacteria are multiplying. This pus tries to go here and there. Where does it go? First, it tracks down all throughout the medullary canal, right? So, if it starts at the proximal end of the metaphysis, it goes down to the diaphysis and to the other metaphysis. So, whole of the canal is filled with pus, but still it's more and more pus is coming. What will it do? It tries to break through one of the areas in the cortex and then goes into the subperiosteal plane. Once it goes into the subperiosteal plane, there will be some sort of collection. It lifts the periosteum. Now you know periosteum has a cambium layer. Once it is lifted or irritated, it forms new bone. Okay. Now once it has lifted the periosteum, sometimes it breaks the periosteum and tries to go into the surrounding soft tissues, and it ultimately breaks through the skin and comes out as a sinus or a fistula. Right? This is what happens in osteomyelitis. Now all the thing is there, the rise in the blood, rise in the intraosseous pressure is the most important thing, because if the rise is there for some more time, whole of the bone gets sequestrated and gets died off. If whole of the bone is died off, there is no meaning in having that bone. You have to go and any dead tissue, the dictum is in surgery, remove it. Got it? Any dead tissue, remove it, debridement. Got it? So, acute inflammation leading to necrosis and suppression, and once you have a periosteal new bone formation, ultimately if you give some antibiotics or if the immunity has improved, what happens? Once the pus has drained out, some resolution of this infection will happen. But ultimately if the dead bone is there inside, it takes a longer time to resolve, because all of the dead bone has to get converted into pus and has to drain out, and the new bone that has formed has to maintain the continuity. Otherwise, if at that portion of osteomyelitis, once the bone has become weak because of multiple holes and necrotic bone not strong enough to take the weight, if the patient walks, what happens? It will break. That is called as pathological fracture. Even that is also a part of the pathology of osteomyelitis. Now this happens once there is a focus in the metaphysis, the subperiosteal abscess, and if such a metaphyseal zone happens to be an intracapsular lesion, once it is trying to break out, what happens? This pus goes into the joint. That is called as septic arthritis. Simple. So a metaphyseal osteomyelitis can lead to septic arthritis at certain sites where the metaphysis is intra-articular. What are those sites? First one is neck of the femur. Second is humerus, proximal humerus. Third is distal end of the tibia, ankle joint, in and around ankle joint. Fourth is elbow. Elbow, humerus, shoulder, hip and ankle. These are the zones where a osteomyelitis can easily get converted into septic arthritis, because the metaphysis can be a part of or within the encapsulation of the capsule. How do these patients present to you? I told you septic arthritis as well as osteomyelitis, treat them as malignant bone tumors. Then what is the dictum in malignant bone tumors? Detect early, treat appropriately. What happens otherwise? You lose the patient. Same thing here. There are at times you lose the patients, but definitely you will either lose a joint if it is septic arthritis, or you will lose the bone if it is osteomyelitis. If you don't identify this condition within 24 to 48 hours, I should say it is 24 hours, sometimes at the max it is 48 hours, because in 24 hours there will be a lodgement and multiplication and inflammatory response starts coming in, and by 48 hours you have pus formation. If once there is a pus formation, there is a rise in intraosseous pressure. By 48 hours you are, by hook and crook, you have to diagnose this condition and treat. Even if you are diagnosing this condition after 48 hours, it is useless, it is waste I should say. So you should be more careful in diagnosing an acute hematogenous osteomyelitis within 48 hours. If you don't do it, it is as good as not doing it, because already the damage has happened. Am I clear? Now for diagnosing it within such and such a short time, you should know exactly how the patient presents to you. Most often it is missed out. The first and foremost important feature the patient comes to is high grade fever with severe pain and swelling in and around the zone. Severe pain and fever. Suppose if a baby or child is complaining of pain in and around a joint or in the metaphyseal zone and is coming with high grade fever, never ever take it light. Always consider it is an osteomyelitis and treat aggressively. There is nothing wrong even if you treat aggressively, but never underestimate. If you underestimate, he can end up in a lifelong disability. Right? That is one. And patient will not be in a position to move the limb because of severe pain, and there may be toxemia once if all this pus is extruded and extravasated into the blood and all the toxins secreted by the bacteria are already gone into the blood. Now locally there may be swelling, redness, local rise of temperature, tenderness, decreased range of motion in the adjacent joint. These are all the extremely important things you need to remember. And how do you diagnose? The clinical history per se is extremely important. One, pseudo paralysis, that means patient not able to move the limb. Localized tenderness, pain, swelling and all those things at a localized portion in the body, and high grade fever. Always have a suspicion it must be an osteomyelitis or a septic arthritis. One. Now once you have taken the history and clinical examination, you have to take the blood sample, you have to see complete blood picture. CBP, what does it show? It shows increase in the WBC count. Okay, more than 11,000. WBC count may be raised, and more specifically neutrophils will be raised, right? Especially in non-specific type of infections, not tuberculosis. We are dealing all with non-specific type of infections. Most important, staph aureus. Now the usual thing what we take out and we examine is for ESR and CRP. ESR is erythrocyte sedimentation rate and CRP. CRP is an acute phase reactant and CRP is more useful than ESR. How come? CRP rises within 6 hours, peaks within 1 day and comes down within 1 week. 6 hours and 6 days approximately. That means what? CRP, once you have an infection, once you have multiplication, enlargement and multiplication of bacteria going in, an acute infectious process going in, the first thing to raise is CRP, not ESR. CRP raises within 6 hours, peaks by 1 day and comes down by 1 week, right? But when you go to ESR, it may take even 72 hours or 3 days to rise at times. If you just take an ESR and say, no, ESR is normal, what happened? Within 48 hours, I said you have to diagnose already. Within 48 hours, ESR is normal. ESR will be normal at times. So, don't ever go by ESR, go by clinical examination as well as CRP, more specifically when it comes to osteomyelitis and septic arthritis. And it takes longer time to come down. Approximately it may take 3 weeks to come down. Even if you have treated, ESR will be there like that for 3 weeks. What does that mean? Sometimes you feel that whatever you are giving the treatment might not be working, but it's not so. ESR per se takes longer time to fall down, right? Next is X-ray, radiograph. How much it is useful? Absolutely useless, right? You have to diagnose within 48 hours. The first sign to see on an X-ray is 3 days. What is the first sign? Most often it is missed out. Do you know what is the first sign that you see on an X-ray? It's not the bony part, it is the soft tissue part. Loss of soft tissue planes is the first thing that you see on an X-ray, and most often it is missed. Most often it is very difficult to see. And the first usual signs what we see on an X-ray, right? The rare fraction in the bone, usually that is seen by 7 to 10 days along with the periosteal reaction. When is the periosteal reaction coming? When whole of the pus is there all throughout the medullary cavity, going here and there and trying to, once it has already pierced the cortex and trying to come to subperiosteal bone and elevating the periosteum, then you are having a periosteal reaction. By then your X-ray is now showing a small feature, that to one faint line of new bone formation, that is periosteal reaction. How much it is useful? Already the damage has happened, so don't depend on X-ray also. Ultrasound, again ultrasound, what does it show? It shows subperiosteal abscess. By then already half of the damage has happened. These are all the important investigations. When you are in doubt whether it is a cellulitis or osteomyelitis, these ultrasound is extremely useful, right? You can see a subperiosteal bone, subperiosteal collection of pus. right? Then bone scan, this is also a very good important investigation. Usually within 1 day bone scan will be positive. What is positive about bone scan? Whenever there is an infection going on, infectious process going on, I told you there is a increase in the pressure and decrease in the blood supply to that portion of the bone. Once this is happening, the bone scan will show a cold spot. That means the blood is not going there properly. That cold spot has a very high predictive value of what? Of a localized osteomyelitis. Usually bone scan we do with technetium 99. It's called a technetium 99 bone scan. And there are other scans also more specific for osteomyelitis. You need to remember these two names because it can come in your exam. Gallium citrate 67 scan or indium 111 scan. Indian 111 scan is WBC radio label scan. What happens? This radio labeling, whenever there is an infection, there is a rise in the level of WBC at that portion. So if you can tag these WBCs, they just go there to the zone of what? Infection, and hence this indium also goes there, which is a radioactive substance, and it gives you more amount of radiation there. That means what? Means that there is a infectious focus over there. But what happens? Indium scan takes nearly 24 hours to diagnose. Once you have given this radioactive substance, you have to ask the patient to come after 24 hours, where all the golden period is lost in watching whether the scan is positive or not. How far it is useful? Right? When it comes to gallium citrate, it may take even 48 hours, so not useful. So ultimately what I mean to say through this slide is your clinical acumen, high index of suspicion are most important to save the patient's limb as well as joint. If you don't do that, gone. It is useless to diagnose after 48 hours, let me tell you. Of course, there are most often we diagnose after 48 hours, but thing is, if you have this strong conviction to diagnose before 48 hours, you will be doing more good to your patients. It's not that useless, of course, but there are people who don't diagnose even if pus is coming out of the body. There are so many instances where the pus is coming out, they say, hey, it is only abscess, you drain the pus, it will go off, but they will never see whether from where this pus is coming. Most often people come to us, to orthopedics like this. So they go to some other surgeon or MBBS doctor or some other person or a quack, the simple collection of pus underneath the skin, they will just drain it. The collection of pus underneath the skin will go out. But thing is, where is this pus coming from? It is coming from deep inside the bone. If you don't decompress the bone, what is happening? The bone is getting died off every day because of raised intraosseous pressure. So always your prime motto is first decompress the pressure within the bone, so that at least the bone, whatever, is having good blood supply. If you can improve the blood supply to the bone, what happens? Once the bone blood is going there, it carries some immunity also. Got it? Because of the pathology inside, once there is an increased pressure, blood supply is decreased, means what? Even the immunity is not going to that portion. Clear? Next, CT and MR. CT and MR also are very good investigations of choice. They can tell you within 1 day, that is 24 hours. CT can show you a gas shadow within the bone, and MRI can show you all the edematous reaction that is going on, all the inflammatory process that is going on both inside as well as out of the bone. Right? They are very good. So within 1 day, you can use bone scan, CT or MR. More specifically, bone scan and MR. And the most important thing you should always remember is, whenever you have a doubt of osteomyelitis, don't ever hesitate to put a needle either into a joint or into the bone directly or subperiosteal region. Aspirate and send it for culture sensitivity and gram stain. If you are gram stain and culture gram stain, usually you get it in 5 to 10 minutes. If it is showing some bacteria, more specifically staph, that means what? It is an infectious pathology and you are 100% sure you are dealing with it, go for the kill. Right?